हेलो हेलो 1 2 1 2 माइक चालू है. हेलो 1 2 1 2 टेस्ट 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 1 2 3 4 1 2 3 4. 6 एग्जैक्ट. हाँ हाँ सिंगापुर टाइमिंग है. हेलो टेस्ट 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 1 2 3 4 1 2 3 4 बस. हेलो टेस्ट 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 1 2 1 2 माइक चालू है. हेलो 1 2 1 2 टेस्ट 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 1 2 3 4 1 2 3 4. टेस्टिंग टेस्टिंग. हेलो टेस्टिंग टेस्टिंग. 6 एग्जैक्ट. हाँ हाँ सिंगापुर टाइमिंग है. हेलो टेस्ट 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 1 2 3 4 बस. हेलो टेस्ट 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 1 2 1 2 माइक चालू है. हेलो 1 2 1 2 टेस्ट 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 1 2 3 4 1 2 3 4. टेस्टिंग टेस्टिंग. हेलो
हेलो हेलो
6
हेलो 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 हेलो
हाँ हाँ सिंगापुर टाइमिंग है.
हेलो 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 चेक हेलो हेलो हेलो
हेलो टेस्ट टेस्ट टेस्ट
हेलो.
1 2 3 4 1 2 3 4
चेक चेक
हेलो टेस्ट 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 1 2 माइक चालू है. हेलो 1 2 टेस्ट 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 1 2 3 4 1 2 3 4. टेस्टिंग टेस्टिंग. हेलो
हेलो हेलो
6
हेलो
एग्जैक्ट.
हेलो 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 हेलो.
Good evening, friends. Welcome you to the broadcast of the postgraduate clinics, which is being done as a academic activity by the Indian Academy of Pediatrics. This activity is supported by a generous grant from Wockhardt Vaccines. It gives me great pleasure to announce that we are now entering the third year of these broadcasts. And we hope that these, and we of course get a feedback that these are useful and helpful to everyone. And we hope that we can continue doing this in the future also, and that you continue patronizing us and listening to these broadcasts. I hope you are aware that you can, if you have a good download manager, you can download this webcast and view it on your own. These are archived also, so you can have a look at those when you have the time or the inclination. A few announcements for the ladies and gentlemen who are in the audience here. I know you have great enthusiasm to participate, but please ask for the mic so that the people who are online can hear what you are asking and saying. Is that okay? Yeah. Next week's broadcast will be from Chennai, and you will get a mail from IAP regarding the same. We would also want to announce that we are coming out with a STEER program, and STEER, I hope you know, stands for Sensitizing to Think, Enabling Excellence and Rationality, which is a program which has been coined by Dr. Y.K. Amdekar sir, and it helps us to think and analyze cases. We are doing a STEER program specially catering to postgraduates, where we will focus on how you should approach history taking, physical examination for your exams specifically. This is scheduled to be held on the 20th of March, and that's a Sunday. And we are, if things work out the way we are working on it, we should be able to broadcast this like we stream these clinics. So for those who are watching this online, you can mark that date in your calendar, and if this broadcast happens, please inform your colleagues about it also, so that they can all benefit from Sir's wisdom. So this is about the steer for postgraduates, which will be broadcast on the 20th of March 2016. Dr. Nikun, should we begin our first case?
Good evening, everyone. My patient, yes, 8-year-old male child, first by birth order, born of third degree consanguineous marriage, Hindu by religion, Maratha by community, residing at Vikroli and hailing from Kolhapur, brought by and informed by father with the complaint of fever, cough, cold since 3 days, and breathlessness with right side chest pain since 1 day. Child was apparently alright 3 days back when he developed fever, which was sudden in onset, moderate to high grade, intermittent, relieved temporarily by medication and not associated with chills or rigor or rash. Along with fever, child was also having cough, which was non-productive initially, dry, but become productive after 2 days of admission, with whitish mucoid expectorant associated with blood streaks occasionally, and also having cold in form of running nose. After 2 days of this above complaints, child developed breathing difficulty and right side chest pain, which was more during coughing and associated with coughing, and not associated with deep respiration. And child feel comfortable while sleeping on left side, on the opposite side of the pain. For above complaint, child was first taken to local government hospital, and where he received nebulization and some oral medication, but not improved. So referred to higher center and admitted in Sion hospital. There is no history of any trauma over chest, no history of recurrent respiratory tract infection which require or any frequent requirement of nebulization, no history of COX or COX contact, no history of cyanosis, no history of palpitation, no history of dyspnea on exertion, no history of pedal edema, no history of weight loss or appetite loss. Past history, no history of admission in the past with a similar complaint. Birth history, ANC registered, investigated, received supplements and 2 TT injections. Antenatal USG scan done at the 8 months of pregnancy, which was said to be normal. Child is hospital delivered, full term normal vaginal delivery, and baby was cried immediately after birth. Birth weight was 3.5 kg, and no any resuscitation required or no any NICU stay. Immunization history, child is immunized till date according to national immunization schedule. Developmental history, child is studying in 3rd standard, average in studying, and achieved all milestones at appropriate age. Dietary history, child's calorie requirement is 600 kilocalorie, and which is met and adequate in amount, and protein requirements is 29.5 grams, which is also met by its diet. Family history, father is 37-year-old, studied till 9th standard, and works welding worker and fabrication worker, and earns 10,000 per month. And mother is 32-year-old, which studied till 7th standard, and she is housewife. Child is having younger sibling, which is male child and 2-year-old. No any significant illness in the family with any family member. Socioeconomic history, family is living in a pakka house with one room and one kitchen. 4 people living together. Separate sanitation facility available and uses tap water to drink. According to modified Kupuswamy classification, families lying in the upper lower socio-economic class.
Can you just summarize quickly the chief complaints and then we can start discussing?
Chief complaint. Child is 8-year-old male child with having acute history of fever, cough, cold, and breathlessness with chest pain. With
Okay. So, you said fever for 3 days and then you said cough, cold and breathlessness. So now as we have been discussing every time, can you tell us what this fever means to you? What interpretations you derive from this fever?
fever.
You described the fever, you said it is moderately high, some adjectives you use. So what interpretation do you derive from that?
Fever is acute in onset with a high grade and not associated with chills or rigor or any rash, and associated with the cough and cold. So it may be any and high grade fever, so it may be any bacterial etiology or cause for any respiratory infection.
Okay, so we'll take cough and cold later. So take the fever alone. So he said fever is high grade and you said without chills or rigors. So what does without chills or rigors mean to you? Does it give you any information as to what could be the possible cause of fever? And suppose it was with chills and rigors, what would it mean to you? Come on, I think we've discussed some of this in the past, so it's just a revision. Anybody? What does chills and rigors mean to you in fever? What information does it give you?
High grade fever.
Okay, high grade fever. What else?
It may be associated with malaria or urinary tract infection.
Okay, so chills and rigors may be associated with malaria or urinary tract. But can it be associated with something else also?
Sir.
What else?
Infective endocarditis.
Process anywhere in the body.
Suppurative anywhere in the body. Then
Infective endocarditis.
infective endocarditis. Then pneumonia. Then so you realize that it can be associated with 10 or 20 or 50 different things. So what does it mean? So does chills and rigors occur only in bacterial infections? Which viral infection can have chills and rigors? Come on. Ask for the mic, yeah? Come on, say whatever. Dengue, yes. Then even influenza is described as classically starting with chills and rigors, okay? So chills and rigors don't have any localizing value, doesn't tell you whether the given illness is viral or bacterial or what, okay? What does chills mean? You want to answer? What does chills mean to you?
Chills means it is a body reaction to fever.
So the patient is feeling cold because it is a chills is a subjective feeling. Patient is feeling cold because of vasoconstriction, so body is trying to conserve heat. That's the first way in which body is trying to raise the temperature. If that is not enough, then the body generates heat by muscle contraction, which is rigor. So that's all. Chills and rigors means just this, that the body is trying to raise the temperature. Okay. Now high fever you said, so may mean bacterial infection. So can high fever mean anything else besides a bacterial infection?
Malignancy is connective tissue disorder.
Can it mean viral fever? Can high fever mean viral fever? Can viral fevers be high fever?
Yes, sir.
So high fever can be bacterial, it can be viral, it can be non-infective like he said. Can it be malaria?
Yes.
Can it be tubercle? So tubercle cannot have high fever. Sometimes tubercle can come with high fever. So the point again is that high fever does not mean bacterial. Okay. So therefore, how will you decide in such a short duration fever what it is? This is a 3-day fever, short duration fever. So how will you decide whether a given fever is viral, bacterial, non-infective? How will you decide?
Degree of sickness of the child.
One second.
So like depending on the matlab the child's status during the between the two episodes of fever, like
Very
whether
good.
is
Excellent. So in the interfebrile phase, what is the behavior of the child?
Sir, the periodicity of the fever can give us a hint as to the cause of the fever. So malaria typically has an intermittent type of fever, and depending on its periodicity, which depends upon a particular strain of Plasmodium. So that can also point towards a particular etiology.
Okay. So that periodicity as per strain of Plasmodium is nowadays not seen because you can have multiple broods at the same time. Okay. So you need not have that typical periodicity described in books. Okay. So what else do you mean by periodicity, and what about your interfebrile behavior? Can you expand on that?
so basically in a bacterial fever, the child will be very sick looking, toxic, and he will not parent will say that he's still, even after the fever subsides, he's not playing. That's the basic
Very
thing.
good. Very
And
good.
in a viral fever, like your fever touches baseline, child is normal, he's playing around, and then again it comes in.
Excellent. Excellent. And what about periodicity of viral or bacterial fevers? What do they?
Basically, it signifies release of a particular infectious agents into the bloodstream from time to time.
Very good. So bacterial fevers will not come down easily with antipyretic and will come back much before the next antipyretic dose is due, whereas viral fevers may respond better. Okay. So you look at interfebrile behavior, response to paracetamol, onset of fever, and then you look at the associated symptoms which you said, cough and cold. Okay?
Rajesh, I have a doubt.
Yeah.
In viral fever, child plays, and in bacterial fever, when the fever goes down, child is sick. Why is that? I mean,
Yeah.
can anyone tell me why that happens?
You understand his question? So why does that happen? So actually I'll make it easier for you. What Anand is asking is that a viral fever child can also be irritable at the height of fever, but as soon as the fever comes down, he plays. And bacterial infection child is irritable at height of fever also and at relatively low fever also. So what does that tell you? Have you ever got fever? Are you happy or irritable when you have fever? So the point is, fever itself can make anybody irritable, including you and me. So when a viral fever child is irritable at the height of fever, it is the fever which is making him irritable, not the disease or the infection. But when the bacterial infection child is irritable, the disease is making him. So that's why he is irritable all along, right?
I think what is happening in bacterial infection is that the antibiotic given or whatever, the fever comes down a little. The bacterial multiplication is not all the time. It's periodic. Like a tubercle bacillus will multiply almost every 24, 48 hours. That's why we give even an alternative treatment or a single dose. So largely the bacterial population multiplies every few hours. So the fever is not due to directly infection, but a tissue injury that results into cytokine production, and that's why fever. Now in bacterial infection, the bacteria keep on exuding some toxin and the toxin continues all through. Whereas the bacteria multiply for a while, lag, multiply again, and therefore, but the viruses don't exude any of that. Therefore, in a bacterial infection, most often, it's a toxemia that keeps up the behavior abnormal. In a viral infection, there is nothing of that kind. Now, there is always in medicine not just the rule to be followed. You could have a bacterial infection which hardly produces any toxin. The child may look a little better. But generally, most of the bacterial, higher the severe the bacterial infection, more is the disturbance in behavior even after fever comes down. So these are the rules of the game. There will be always exceptions. And I think today you need to master the rules. And once you master the rules, you start looking beyond rules and say, oh, there could be an exception. But what we are discussing is first the rules of the game. As a good postgraduate, you should know rules of the game very well. You will be 90-95% correct. As you go beyond that, then exceptions come. So this is not the rule. Don't close your eyes and say, he was playing, so he can't have a bacterial infection. But start with a presumption that very likely he does not have a bacterial infection. You are clear about that?
Okay. Now we go on to the cold and cough. Okay. So you said that the cough was initially dry and then became wet, right?
Yes, sir.
Now, see, we have discussed this many times. You have to be little more exact, if possible, as to when the cough started. So when did it start?
Started before 3 days.
No, before
Okay.
3 days means if fever started, let's say on day 1, cough started on day 1. Is that important? Maybe you've not asked it in so much detail, but is it important? So I'll give you 2-3 situations. I'll give you a situation where cough since 7 days or 4-5 days and then some fever. This is situation 1. Second, cough, cold cough today and then fever tomorrow, high fever. And third, high fever today and then 3 days later cold cough. What are the different 3 situations? Does it make any difference?
The second situation wherein there is a cough and cold today and then followed a day or two by fever. It could be a simple viral infection and then superadded by a bacterial infection. That could be.
So why does this viral infection have a cold cough today and fever tomorrow? Sometimes you can have a prodrome. So this is a very short duration. So mild cold, mild cough and then fever immediately. If you look, the most prominent complaint at this stage will be high fever, which is the complaint tomorrow. So that tells you this is an infection and this is a viral infection. What about 4-5 days of cough and then some mild fever? Come on. Does it make any difference? So 4-5 days of cough and mild fever would just mean that this is not an infection, because infection has to start with high fever. So that means this fever is non-infective. Now it could be inflammation but not infection, and typically this will be seen in allergic coughs. So whenever a child has allergic cough, they can get mild or low grade fever somewhere in the illness, but it is not starting with high fever. And if you again ask what is the chief complaint is cough, not fever. Whereas in an infection, chief complaint is fever, right? And the third one I said, high fever today and after 2-3 days cold cough, that is again a viral fever, right? So it is important to ask details of when the cough started. But anyway, you are telling us that the cough was initially dry and became wet later. What does that mean?
Means
Can you talk about the origin of the cough when you say that it became wet later? You described the sputum also.
yes, it became wet after 2 days of admission, means after
5 days of the illness.
illness.
Very good. So now this is very important. You are saying that the cough became wet 5 days after the illness and 2 days after admission. And then what else did you say about the cough?
Cough was whitish in color and mucoid. With
And
the blood streaks
with-
occasionally.
with occasional
associated
blood
with-
streaks. Okay. So just cough with some expectoration and occasional blood streaks. So what does this tell you?
This.
Where is this cough originating from? If we were to divide the respiratory system into 4 major anatomical parts for us clinicians, first being airway, second being parenchyma, third being pleura, and fourth being interstitium, where do you think this kind of a cough is originating from?
Maybe from airway.
Parenchyma.
Very good, parenchyma. Why? You're right, absolutely right. Now justify that. Anybody else? So parenchyma related cough comes up later in the disease. So he said cough became prominent 5 days after the illness started. So parenchymal cough, in our mind we take it as a pneumonia. So in a pneumonia, cough never starts on day 1 very prominent. It starts later in the disease and becomes prominent later. Plus you said it is productive. Okay. So that makes it parenchymal. Now what about that cold?
Cold is about there is running nose.
So see, this is always a trap. So we have to be careful. One, there may not be a running nose at all. So many times parents also talk of cough cold in the same breath. You have to reconfirm whether there is a running nose actually. And the second situation is running nose is often an allergic cold which has been there ever since or has been there 100 times in the past. Then it loses its localizing value today. So you have to differentiate both, whether there is actually a cold and whether it's just an allergic cold and it's fooling you. Okay? Okay. Then you said there was chest pain.
Chest pain.
So what does that mean to you?
Chest pain was
What does it mean to you? Yeah.
more during coughing, and child feel comfortable while sleeping on the left side, on opposite side.
On opposite side.
Yes.
Okay. And where was the pain?
Pain was in right side, lower side of chest.
So if child slept on the left side, the child felt comfortable.
And
So what does this mean to you?
It's unlikely to be a pain of pleuritic
Why?
or a pleural irritation, because generally when the pain is in because of pleural irritation, the child would feel more comfortable when he's sleeping on the side of the pain because there would be minimum contact and friction between the surfaces. But in this case, the child is complaining of pain in the right lower chest, and he says it's increased on coughing, and it's more comfortable when he's sleeping onto the other side. And it's not exacerbated on breathing also. I mean, it's only on coughing, so it could be a musculoskeletal pain for all we know, and which is probably related to the cough.
Okay. So actually, if you go by the sequence of events, high fever followed by cough, and the way you have described the cough, I've started looking at a parenchymal lesion, and if I've started looking at a parenchymal lesion, then I expect some pleural involvement secondarily. So I expect pleural pain. The odd point is that he is feeling better by sleeping on the opposite side. That's the only odd point. When did breathlessness come in?
breathlessness come on day 4 of illness with before the chest pain.
Yeah. So what does that mean to you?
Means
So again the same thing, that the breathless, so you have a child who started with fever. We said we will discuss and decide whether this fever is viral, bacterial, whatever. Then this child gets minimal cough, but that we have not been able to exactly clarify when the cough started. Then this child becomes breathless by day 3, day 4. So a child who started with high fever and becomes breathless by day 3, day 4, this is again suggestive of parenchymal involvement. Then of course the cough worsened later and became rusty and all that. So all that fits in with parenchymal involvement, right? So clinically you would say that this child has a parenchymal lesion. Okay. Now, we want to do this as a short case, so we'll probably get on to examination. But in your history, there were a few. Can you quickly go through your rest of the negative history?
Negative history. No history of any chest trauma. No history of recurrent respiratory tract infection or frequent requirement of nebulization. No history of COX or COX content.
So one sec. So no history of frequent requirement of nebulization is not a good history. Okay. Why? Because anywhere, any child who comes with any respiratory complaint is first nebulized. So doesn't mean that nebulization is right. So a better question would be no history of frequent coughs in the past. Because if there is history of frequent coughs in the past, it tells you that this is likely to be a child with hyperreactive airway disease. Okay? Okay. I think we'll get on to examination because we have to do a longer case later. Can you get the child?
I think what we are doing in this kind of a teaching program is first allow you to do what you want and what you know, and then try to show you how you can do better. It's not a rehearsed program. Neither any one of you know the case nor we know the case. And nobody has coached him how to present, how to be perfect. Because in real life, we don't get time to prepare and then see a patient. So our teaching module is, let him make some mistakes. And I'm sure many of you might have felt better that you are not speaking because you also could have made the same mistakes. So there is nothing wrong in making a mistake. What we here is to find out how you can do better. So when every time it is said that, oh, we must know little more about fever, little more about cough, you take home the message that you want to know many more details next time. That is the learning. Learning is not performing the perfect act when nobody knows why he performed perfect act. Teaching is let him make mistakes and then you correct. Once you make a mistake and you get corrected, oh, you will know it forever. But if you see a perfect drama, nobody will much learn out of it. Even we make mistakes and we hope to correct. So feel free, learn every time. But next time you should do better than this time. If you keep on doing that, at the end of 3 years, you are a very good pediatrician. So keep that in mind, right? Yes.
Come now, somebody wants to volunteer to examine? Best place and best time to examine. Not exams. Come. Come, sir, he's here one. Come. Very good, come. बेटा आपको ठंडी नहीं लग रहा है ना? हाँ?
First, just an inspection. Don't touch him and say what you can make out.
8-year male child, lying comfortably on bed, conscious, well-oriented. On general inspection, he is moderately built, moderately nourished, and moving on to upper respiratory tract.
What is his look? Is he comfortable? Is he sick looking? Is he
comfortable? And on inspection, trachea appears to be central and his breathing movements are as compared to, it is increased. It is around it is around 40 uh, with minimal intercostal indrawing is there. Apical impulse is visible in the mid-clavicular line in the fourth intercostal space. As compared to left side, there is a decreased movement on the right side, chest movement. His breathing pattern is abdominothoracic. However, there is no dilated or visible veins or any scar, and his otherwise he is breathing comfortable. So I will move to palpation.
Can he take off the shirt if he doesn't feel cold? IV sammal.
First, I will palpate for the trachea. Stay. थोड़ा slide flex कर. Trachea appears to, I mean, it is not deviated to any side.
Any corrections in that? Anybody wants to suggest anything? Correct. So first time you did not do that. So what you are supposed to do is feel the trachea and then feel the gap between the sternocleido head and the trachea on both sides to see any side gap is more. Very good. Go ahead.
There is right-sided appears shoulder drooping appears to be with
Okay, for shoulder drooping, what should you check whether it is correct or spurious? Very good. Spine. So spine is very important. If there is any postural curvature or otherwise of the spine, shoulder will droop. Wrong side, matlab, without any pathology in the respiratory system. Okay.
but spine is central, sir. Apical impulse is palpable. Apical impulse is palpable. It's in mid clavicular line. Now I'll move on to percussion.
You said on inspection movements are less, so you need to confirm whether movements are less.
So I will see for the supraclavicular. बेटा सांस लो, सांस लो. अभी सांस लो. There is slight decreased movement on the right side.
Actually,
Below the inframandibular.
so better way is to see that your full palm encompasses the chest of the child. So this part should not be as a lifted up. It should be touching the child. Your two thumbs should be touching each other in the midline so that you can judge the movement of the thumb from the midline, and you should be holding this very, very lightly because you want your hand to move with the movement of the chest or the lung. So this is just touching, it is not pressing, it is just touching the chest wall. Okay?
But it is definitely decrease movement on the right side, inframammary area. जब हाथ रखता हूँ ना तब 1-1 बोलना है. There is no tactile frematus on the this thing right side.
No means it is decreased.
Decreased. Question. First is supraclavicular. There is a stony dull note on the right infraclavicular.
So two things. When you are comparing, don't compare the area over the heart with the other side because that's not going to be the same. So you compare the peripheral expectedly resonant area with the area on this side, right? Not
Definitely stony dullness is there.
The second thing is don't use the word stony dull. Say there is a impaired note or dull note. Okay? Because these differences between stony dull and impaired are very difficult to quantify.
Okay.
You want to percuss backside?
Backside, I'm not getting the difference, but it is there on the right, only right inframammary and mid axillary.
Okay. Now auscultation.
So there is a question from the web, Rajesh, which I think you should clarify. The question is that does the absence of crepitations rule out bronchopneumonia? So there are two parts of this question. Will you take both of them?
So first of all, crepitations mean those moist sounds which we hear. So first of all, they are not necessarily seen in parenchymal disease. They can always also be seen in interstitial disease, also be seen in airway disease. So that's one. Second is it depends on the stage of the parenchymal disease when you will get crepitation. So you will initially get bronchial breathing, then as the area kind of starts healing, you may get crepitations. And finally, bronchopneumonia is not a terminology to be used. So it was a old terminology which was used. We should avoid using that term at all.
So there's one more question. The gentleman wants to know that if there are no crepitation, should I call it bronchiolitis? And if there are crepitation, should I call it bronchopneumonia? So, as far as bronchiolitis is concerned, this is not the age group when you will see it. Secondly is the involvement of the lower, smallest airways. There are usually no chest signs and there is only hyperinflation. So crepitation has got nothing to do with bronchopneumonia, I mean with bronchiolitis.
Correct. So in fact, if you were to ask which is the sign of bronchiolitis, it is tachypnea. So you have to look for a lot of tachypnea as your sign rather than any other sign, even to think of bronchiolitis.
And the sign for a consolidation or a pneumonia would be its distribution rather than a crepitation.
Yeah, which we are just coming to. I was about to question him on that.
Breath sounds are decreased in the infra mammary and mid axillary line. Even vocal resonance has decreased, and there is a decreased air entry on the right side, that is infra mammary and mid axillary line. On the right side, infrascapular region, it's almost normal, means it's normal, equal air entry on the both infrascapular regions. So luckily suggestive of middle lobe on the right side, because infrascapular region has been spared on the right side.
Okay. So I'll come to you in a minute. So if we were to summarize what he has found a impaired note, decreased movement, reduced air entry, decreased TF, decreased vocal resonance, all on the right side inframammary and partly in the axillary region. And more or less he has found the backside fine. Now we have listed 5 signs, okay, 5 clinical signs. Decreased movement, impaired note, decreased air entry, decreased TF and decreased vocal resonance. How do you say this is a consolidation based on these 5 signs? Because these 5 signs are also seen in a pleural effusion.
It could be a consolidation with a synemonic pleural effusion.
Okay, so when there is a consolidation with a synemonic effusion, clinically the signs are of the pneumonia or of the effusion or of both?
I think it would depend upon the size of the effusion.
Synemonic means what? What is the meaning of synemonic?
Following in pneumonia, there is a mild amount of pleural effusion because of the inflammation, that because of active process of inflammation.
What was the other word for this effusion?
Parapneumonia.
Any other word? When we were students, they used to call it sympathetic effusion. So this effusion is in sympathy with the pneumonia. Okay, sharing sympathy.
Rajesh,
so which is a bigger
they are
problem?
Still students.
Yeah. So what's the bigger problem? Bigger problem is pneumonia. So this effusion is always tiny. Okay. And therefore your signs are of the pneumonia. Okay. So coming back, is this pneumonia or is this effusion? Please ask for the mic.
Based on anatomical distribution of where we are getting these signs.
Excellent, excellent. So what she is trying to say is that the signs are common to pneumonia and effusion. Where the signs are decides that this is a pneumonia. So because he made a point that these signs are not there posteriorly, they are there only anteriorly. This is the distribution of the right middle lobe, he said, and that is why this is a pneumonia. Okay, so you don't have, for the web person who asked about creps, there is no bronchial breathing yet and there are no creps yet, but still you can call this a consolidation.
Now, how can you call it a consolidation when you don't have a bronchial breathing, you don't have a foreign sounds? I will call it a collapse. Okay, collapse is the same distribution like a consolidation, and collapse has no foreign sounds. Collapse has an impaired note. Collapse has a diminished air entry.
The trachea
Why?
is central in position in this patient, which should have been pulled to the same side if it was a collapse. And the pleural effusion, if it is the pneumonic effusion, it will not be that big enough to push the trachea to the other side to compensate.
The collapse has to be large to show the mediastinal shift. Okay, and if the collapse is not so large, just the middle lobe collapse, neither the trachea, which will be upper lobe collapse, will probably much shift. So if you don't find a shift, you cannot say there is no collapse. You give me something better. So same thing. Mediastinal shift is apical impulse or a tracheal impulse. So how will you still tell me that this is not collapse but still consolidation? See, by and large the consolidation will have a foreign sounds. May not have a bronchial breathing. Bronchial breathing comes up in consolidation only when it totally evolves to be a consolidation. In pathological term, they call it a gray hepatization. Okay. But to begin with, in consolidation, there is only foreign sounds. Then comes the bronchial breathing. Then the resolution comes, bronchial breathing disappears, but the creps are still there. And then the pneumonia gets better, creps also go down. So there is no stage by and large. When in a consolidation, there is neither a bronchial breathing nor a foreign sound. When you get that stage, you have to be very careful whether it's a collapse and not a consolidation. So that's number one. In a routine consolidation, that is not acceptable. Almost like an X-ray. In a typical X-ray of a consolidation, you want an air bronchogram. But 5% of pneumonias on an X-ray may not show air bronchogram. Those are exceptions. So you are telling me this is an exceptional consolidation. I want you to tell me why is it not a routine collapse. You convince me it is consolidation, then I'll accept it, exceptional consolidation. But it looks like a usual collapse. So who will take this? There was a chest pain, there's a pleural disease. Okay. But in which consolidation, okay, you will not get the foreign sounds? The answer is if it is a collapse consolidation. Okay. And tell me an etiology of a common etiology of a collapse consolidation. Pathologists always talk in terms of collapse consolidation. What etiology? Tuberculosis. There is a lymph node there, primary complex. It becomes a progressive primary complex, so you get pneumonia. But the lymph node is still there. So lymph node may press on the bronchus, so collapse, and the infection may spread to the parenchyma, so consolidation. Collapse consolidation is a classical feature of a tuberculosis. Okay, so now say, is this TB? It's a collapse consolidation. Okay, both together. Of course, in even stage of resolution, when there is a lot of mucus secretion, mucus can block the airway and give you almost like what a collapse consolidation is. You can see how the signs can so much differ. So now you will have to tell me whether this is a bacterial pneumonia or is it a tuberculous pneumonia. Typical collapse consolidation is a tuberculous pneumonia.
So how will you say that?
Okay, both together. Of course, in even stage of resolution, when there is a lot of mucus secretion, mucus can block the airway and give you almost like what a collapse consolidation is. You can see how the signs can so much differ. So now you will have to tell me whether this is a bacterial pneumonia or is it a tuberculous pneumonia. typical collapse consolidation is a tuberculous pneumonia. A 6-month-old child comes with a history of 3-4 days of
So how will you say that?
Okay, both together. Of course, in even stage of resolution, when there is a lot of mucus secretion, mucus can block the airway and give you almost like what a collapse consolidation is. You can see how the signs can so much differ.
Sequence of events is this.
So now you will have to tell me whether this is a bacterial pneumonia or is it a tuberculous pneumonia. Typical collapse
Not necessarily
consolidation is a
extrapulmonary.
tuberculous pneumonia.
How does it differ pathology wise? Sir gave examples of TB which present acutely. What is the pathology in those examples? Pathophysiology, pathology.
Autoimmune.
Very good. Immune mediated.
And then for the collapse consolidation of primary complex, what we are talking about is not an immune response. This is a tuberculous pneumonia. Typical collapse
Not necessarily
consolidation
extrapolation. How does it differ pathology wise?
So basically,
Sir gave examples of TB which present acute. What is the pathology in those examples? Pathophysiology, pathology. Very good. Immune mediated.
Collapse consolidation of primary complex, what we are talking about is not an immune response. This is a tuberculous pneumonia. Typical collapse
Not necessarily
consolidation
extrapolation. How does it differ pathology wise?
So basically,
Sir gave examples of TB which present acute. What is the pathology in those examples? Pathophysiology, pathology. Very good. Immune mediated. Was this child was absolutely all right 5 days back. So that itself throws out all those pathologies, no? Okay? And then so many other symptoms which will not fit in that, the sequence of events as she said. Okay? Fine.
Rajesh.
Yeah.
So there was another doubt which has been brought up about the vocal resonance being decreased and therefore it should be an effusion. I think we'll clarify it once for all. It's not the sign that you elicit, but the distribution of the sign which decides
Because
whether
this
it's a
child was
consolidation
absolutely
or
all
not.
right 5 days
So
back.
the distribution
So
is
that
low
itself
bar,
throws out all those
low bar
pathologies, no?
pathology. If
Okay?
it's
And
crossing
then so
low,
many other
then
symptoms
nothing
which
goes
will
to
not
it.
fit in
That's
that,
what
the
this is
sequence of
saying.
events as
It
she
gets very
said.
confusing at
Fine.
times.
Yeah. So
Rajesh.
just one line
there
to
was
add
another
to
doubt
that. The
which, has been
classic
brought up
teaching that in a
about the,
consolidation vocal resonance should be increased
vocal
is
resonance
based on the
being
assumption
decreased
that the
and
pleura
therefore it
is
should be an
totally
effusion. I
normal
think
and
we'll
is
clarify
not
it
doing
once for all.
anything to
It's not the
hamper
sign
those
that you
waves.
elicit, but the
Whereas when the
distribution of
pleura
the
is
sign
also
which
inflamed,
decides
this child
whether
was
those
absolutely all right 5 days back. So that itself throws out all those pathologies, no? Okay? And then so many other symptoms which will not fit in that, the sequence of events as she said. Fine. Yeah. So
Rajesh.
just one line
there
to
was
add
another
to
doubt
that.
which,
The
has been
classic
brought up
teaching that in a
about the,
consolidation vocal resonance should be increased
vocal
is
resonance
based on the
being
assumption
increased
that the pleura
therefore it
is
should be an
totally
effusion. I
normal
think
and
we
is not
clarified
doing
once.
Come on, anybody else?
Now you may recall that at the top of effusion there could be a bronchial breathing. What is this funny? Pleural effusion, at the top bronchial breathing, at the bottom no bronchial breathing. So what is happening really? So foot conductor, but the sound does not reach the fluid at all. In between there is a lung which has been abnormal. So in a massive effusion, the collapse may be so complete that the bronchus may almost communicate with the fluid, in which case the TBFVR is increased. But in general, there is some amount of lung tissue collapsed because of the pressure from the pleural effusion, and therefore the sound comes from the airway, gets dampened by that lung, and does not reach the fluid, and therefore even if the fluid is a good conductor of sound, ultimately TBFVR is not much seen. But occasionally in a small infant, where there is a large effusion, the lung totally collapses. Almost there is nothing in between a bronchus and the fluid, in which case you will even get an increased VR, increased TVF, and even a bronchial breathing. So again the point that Anand made, science in respiratory system could be anything. A cavity can have no science, cavity can have any science.
And still you have to say why it's happening. That is the fun of that.
That is the fun of it.
And I think that is the way we have discussed the chosen, and that also said that anatomical safety is a massive.
So now what is your final diagnosis on this?
8-year-old male child, activity of right side, to rule out right side, or least likely maybe. Second one is Cox pulmonary, to rule out Cox.
Okay, so actually when you are, this was as classical as could be, so you should not say to rule out. You should say confidently, clinically, this is right middle lobe pneumonia or consolidation, and the history is so short and acute. Why you want to say that to rule out tuberculosis unless there is something wrong in your history? So if he is not an absolutely normal child 5 days back, then it's a different story.
But he is not ill looking, right? Acute pneumonia is ill looking. Tuberculous pneumonia is not ill looking. You said comfortable, not ill looking.
He's been admitted for the last 4 to 5 days and
So
received
point I am making is, in an exam you will find a non-ill bacterial pneumonia. Okay. And you will still say that yes, he is already partially treated.
Ask him.
So in a scenario where the patient is presenting with the same symptoms but has a history of Cox contact, would it be advisable to screen for TB in that case?
So a lot will depend on your history and whether the child is normal before the onset of these symptoms, and then how classical or how good is the progress. So like high fever to begin with, followed by breathlessness on day 3, day 4, that's very typical of a bacterial infection. So just that contact may not change the story.
I think which contact you want to further examine. A contact where there is a risk of getting infected and risk of getting a disease. At this age he has not. So we will not even do his, today that tuberculin test and the IGRA, the tests are not meant for diagnosing TB. In fact, the WHO has said that Manto is getting over-diagnosed on TB. Therefore, they consider that that's not a dependable test. And of course, today Gene Expert has been available all over. So that's the answer of that. Similar situation comes in infective hepatitis. When you have got a simple viral hepatitis, why do you want to do Australia antigen? You have no business to do that routinely, but the whole world keeps on doing it as if he did not have Australia antigen positive before he got jaundice. How does it make a difference? No. So, no.
If the child is less than 6 years of age, whatever be the diagnosis he has today, if he has a contact with tuberculosis, to protect this child, you will screen.
Absolutely. Yeah. What I said, I did not complete. His age does not need. Anand has clarified, under 6 years, contact must have an evolution of evolving infection must be picked up.
Okay. So quickly, how will you treat this child in 1 or 2 lines? And if you have the X-ray, show us, and then we'll move on to the next case. How will you treat this child?
First, sir, I will treat symptomatic treatment for fever, cough, and cold and breathlessness for nebulization.
Speak it to the mic.
I will first treat the symptomatic. I will give symptomatic treatment with for fever, cough, cold, and breathlessness and nebulization, and start antibiotic.
Which antibiotic?
First, I will start with augmentin.
Okay, so amoxicillin plus clavulanic acid. Why amoxicillin plus clavulanic acid? What makes you choose that antibiotic?
Because it helps.
Okay. Anybody else?
Broad spectrum. Sir. I mean, it covers gram-positive, which means common pathogens which is causing pneumonia.
So why not ceftriaxone? It is still broader.
Again, starting with lower line is better. I mean.
So how do you choose an antibiotic? On what basis do you choose an antibiotic in any situation?
What type of etiology we are suspecting?
Very good.
Organism.
Very good. So which organism you are suspecting here?
Strepto.
So community acquired gram positive organism, right? This is not the age for H influenza, and you are not suspecting E. coli or Klebsiella or anything. So you are suspecting only community acquired gram positive, right? So even plain amoxicillin would be good enough. Okay, so amoxicillin or this with clavulanic, but plain amoxicillin is also bigger the child, more narrow can be your choice. Okay, why nebulization?
Nebulization.
And which cough syrup? You said symptomatic treatment for cough. So which cough syrup will you give him?
Child having breathlessness.
So see, any child who is breathless does not need to be nebulized. Okay, so let's kind of de-learn this fact that any breathless child has to be nebulized. So nebulization is for the specific purpose of delivering a bronchodilator in most situations, and maybe in occasional situations other medicines, like in a CF you may want to deliver some other drugs to the system to dissolve the viscid secretions, but otherwise no. Okay, so nebulization not a must for everybody. Okay, and which cough syrup? Anybody?
Bronchodilator.
Why bronchodilator? This is a acute bacterial infection. He said no past history of frequent cough. So why a bronchodilator?
So guaifenesin to reduce irritability, to reduce the impulses which are going to the cough center.
Okay. Why does a pneumonia cough?
Because there is because of local irritation to the because there is mucosal irritation, so that will lead to sensitization of the nerves.
So we said pneumonia coughs later in the illness.
Why does anyone cough? What is the physiology behind a cough?
Take the mic.
It could be an irritation, like of the pharynx, but mostly it's a secretion that has to be thrown out from your.
Excellent.
It is an attempt by the body to clear the airways. So when does a pneumonia have secretions coming into the airway? At which stage of pneumonia?
The stage of red hepatization, the active pneumonia.
When it is getting treated, when the whole thing is getting resolved, that's the time the cough is worst, and that secretion has to be brought out. So why do you want to give a cough syrup to suppress this? So suppression is out of question, right? So that secretion has to be brought out, and when everything is brought out, the cough will automatically stop. So pneumonia cough does not need any treatment. It does not need any cough syrup. Okay?
Why don't you add something to that and say any cough does not need treatment, only some discomfort has to be taken care of. That's all.
I think the cough is treated only by two ways. Treat the cause of the cough, okay, in this child pneumonia, or if the cough is not the cause is not treatable, then let the child not perceive his irritation. Okay, he doesn't know his airway is irritating. What does that mean? He should be put to sleep, or he should get distracted so that he does not perceive, right? Whole day the children cough and play. They are not disturbed. At night they are disturbed because they are not playing. There is no distraction. Put them to sleep. What do the cough syrups do? Most of them have antihistamine. They put them to sleep. When they sleep, irritation exists, but it's not perceived. If it is not perceived, there is no reflex, there is no cough. And the parent said, whole night he had no cough. In the morning, he anyway distracts himself. It's like any pain needs a relief based by distraction. When you have a headache, you put a balm here. What does a balm do? Distract your attention from headache to that irritation that you have willfully applied. Even if you applied the balm to the soul, same relief would occur, but mentally you want it close to the head, so you use the forehead that God has given. Okay, otherwise how does the balm treat? So treatment of cough is a distraction, either by sleep or by voluntary distraction. No cough syrups.
So? So why wouldn't you give a mucolytic?
Okay. So see, we believe that mucolytics and expectorants don't work in children. They work only in older adolescents or adults. So in children, mucolytics and expectorants have no role. And again, mucolytic is really required when there is a abnormal mucus disease, like a cystic fibrosis or something. Routinely, you don't have to lyse that mucus. Okay?
See, most of the children can't cough effectively. Younger children can't cough effectively at all. They just cough but of no use. So expectorants are useless. When there is a pain here or an illness, oh, he does not want to cough. How can you make him cough? Expectorants don't do anything. They help you to expel if you are able to cough well. Okay, it's like a sleeping pill. Sleeping pill, you need first to help yourself to sleep, and the pill puts you to sleep. But if you walk around, sleeping pill will make you miserable. So that's why the cough syrups have no role really. Mucolytics, expectorants, cough sedatives, antihistamine, all probably are useless. So typically, medically, rationally, scientifically, cough syrups have no use. Okay.
This is a chest X-ray with the PA view, well exposed, centralized with the right side, low, middle and lower zone opacity with air bronchogram within. Most likely right side middle and lower lobe consolidation.
You should use the one or two other words. So you should say well defined, homogeneous. Okay, well defined because you can see the margins properly. Homogeneous. Okay, opacity. And the air bronchogram. Can you show us the air bronchogram? Okay, very good. Okay, fine. Okay.
When you read an X-ray, don't forget to read what is not obvious. What is obvious is seen already. What is not obvious is hiding. So how will you go simply by A, B, C, D, E, F, G, H? A for airway, B for bones, C for cardiac, D for diaphragm, E for exposure. F for Fisher, G for gastric bubble, H for hilum. You will not miss anything. Okay. For example, sometimes you are shown a X-ray chest of a thalassemia measure. Okay, he has got a little large heart because he is chronically anemic, and his bones are not seen by the candidate. His ribs will tell you that there is something going on there. So remember, A, B, C, D, E, F, G, H, whatever is obvious is obvious. Okay, which completes almost the entire look at the X-ray, right?
Good evening. My patient, 10-month-old male infant by name Ajay Waghela, second born to a distant consanguineously married couple, hailing from Gujarat, residing in Virar, Hindu by religion and Wagri by community, brought by and informed my patients with a history of one episode of a paroxysmal event one day back. I would like to begin with the birth history as it assumes significance. The baby was born of spontaneous conception at the maternal age of 21 years, diagnosed at 2.5 months of amenorrhea, registered, immunized, only one ultrasound done during pregnancy at 2.5 months of amenorrhea. There was no history of fever with rash in the mother during the pregnancy or exposure of any drug or radiation, except for the iron and folic acid medication which she was taking regularly for 3 months. The baby was delivered after 9 months of amenorrhea. It was a hospital delivery with a birth weight of 2.5 kg, normal, cried immediately after birth. There was no history of any requirement of resuscitation or a history of NICU stay. The baby was kept with the mother in the postnatal period, following which it was feeding well, and the mother and baby were both discharged at day of life 3 of the baby. And during this phase, there was no history of excessive cry or feeding issues in the baby. The baby was apparently alright up to the age of 1.5 months, when the mother noticed excessive cry and stiffness beginning to develop in the limbs, equal in both the upper and lower limbs. The stiffness was gradual in onset, slowly progressive, and described by the mother as difficulty in making the baby wear the diaper and difficulty in sometimes carrying her own baby. There was no medical attention sought at that time for the same. At the age of 4 months, when the baby had failed to achieve a neck control nor a social smile, the baby was taken to a tertiary referral center, wherein the baby was assessed and a few medications were prescribed, and the patients were regularly following up for a month or 2, and then they stopped follow-up at that center. There were no details available of the same. At the age of 6 months, the baby was taken to Wadia Hospital, wherein the baby was admitted for 18 days. The baby was admitted with no complaints. He was taken in view of the same complaints like increasing stiffness and not achieving neck control nor a social smile. The baby was admitted in view of evaluation, admitted for 18 days, investigation with blood investigations, imaging studies, auditory studies, and discharged at the end of 18 days, and the parents were counseled about the baby's condition. Following this, the baby has been at home with the mother and has had no significant issues till 1 week back, when the baby had a history of fever which was of acute onset, moderate grade, not associated with rigor, and no diurnal variation appreciated, and it was relieved on medication. There was also a history of cough which was non-spasmodic, non-paroxysmal, and not associated with post-nasal vomiting. So the complaint for which the baby was brought to the hospital, there was the first episode of a paroxysmal event at 9 p.m. in form of a prolling of the eyeballs and tonic posturing, and not associated with fever at that time of the episode. There was deviation of mouth to the left side, and there was no frothing from the mouth, and the episode lasted nearly 10 minutes, and there was a history of post-ictal drowsiness for more than half an hour. The baby was taken to a private practitioner in Virar, observed for the night, and referred to Sion Hospital in the next morning. there is no history of weakness of any body part. There is no history. Currently, there is no history suggestive of any cranial nerve deficit or involuntary movements. There is no history of vomiting. There is no history of trauma or ear discharge or history of convulsions in the past in the baby, or there is no family history of epilepsy. There is no history of COX or COX contact in the baby. There is no history of constipation or bed sores or a history of recurrent infections in the baby in the past. The past history and the birth history have been elaborated in the history of presenting illness. So immunization, the baby who has just received the birth vaccines, it's partially immunized. Feeding, the baby began to feed from the breast within an hour of the delivery, was feeding well with no issues for nearly the first 6 to 7 months. The baby was begin on top feeds at around 1 month in view of inadequate milk output, was taking vati and spoon feeds well. But at the age of 7 months, the baby refused to accept feeds from the mother and was attempted to put on semi-solid top food, which the baby failed to accept in the form of regurgitation and vomiting, and the baby was continued on a milk-based diet, which he currently continues to consume in the form of a milk-based diet given too early. The baby doesn't cry for a feed, or there is no history of demand for feed. Coming to the developmental history, gross motor, there is no neck control achieved. Fine motor, on inquiry, there is only an appearance of a clenched fist. Occasionally in the child, there is no reaching out for objects present. Language, the baby does not exhibit any cooing sounds. There is no social spine. So the developmental quotient is that of a neonate. Social history, the baby is born to a 22-year-old father, educated up to the 7th standard. He makes boxes. 21-year-old mother, studied to 3rd standard, a homemaker, has an elder sibling who is 3-year-old with no health related issues. They stay in a one-roomed Paka house which is ill ventilated, and they belong to the lower socio-economic status according to modified Kupusami classification.
So can you tell us in 3 sentences what the story is and what your thought process is as far as what is happening to this child?
Basically, there is no history of perinatal insult in the child. Secondly, there is a history of global developmental delay. And thirdly, he's come with an acute paroxysmal event to the hospital.
Yeah, but what's his age? And
He's 10-month-old male child with no significant perinatal history, with developmental history suggestive of global developmental delay currently, and with a history of a respiratory tract infection prior, currently come with one episode of paroxysmal event.
Correct. And no significant postnatal history also.
Yes.
So when was the onset?
1.5 months of age.
So no significant postnatal event
history.
and no significant perinatal and antenatal event. Then what's the problem?
Again, in antenatal period, how was the pursuing movements by the mother?
Yeah, the mother experienced quickening at around 5 months of the pregnancy. Since she was gravid at 2, she did not find any differences in the perception of movements while compared to the previous pregnancy.
Why do you want to know that? So such a child who did not move becomes a delayed
Sir,
development.
there is an entity called as intrauterine stroke or intrauterine seizures. Because of that, there is increased movement. That is the one possibility. That's why I wanted to know.
Okay, but usually that movements history is kind of more important if you are looking at something like an SMA or something, then that history is more important. Otherwise,
Like the way you defended, even with difficulty, but yes.
Okay. So when do you think is the onset of the problem?
Sir, initially also there were in the perinatal period, postnatal period, there was no excessive cry or feeding issues which would have been expected in a child, currently assessing the child, we would have expected a significant perinatal issues.
Fine, so that means that there was no birth asphyxia, which is okay,
It's
but
okay.
can there be other causes? Can there
Again,
be?
consanguinity is important. Is it
The distant consanguineous married couple.
Okay, so distant consanguinity. What about antenatal? Can the cause be prenatal or antenatal? Yeah.
There could be the history of fever with rash in the mother is important too.
Yeah, which history you may or may not get. So that you will only be able to sort of confirm when you examine the child, but that history, if it is there, it helps. If it is not there, it doesn't help. Fever with rash and all in mother.
Touch infection, fever with rash with lymphadenopathy, or mother is admitted for pedal edema or anything. Has to be
Correct.
important.
So there's congenital infection present like this. So why are we worried about congenital infection?
Weight gain during the pregnancy.
Story is not like a congenital infection.
Weight gain during the pregnancy, which would signify the fetal growth.
No.
But the birth
See,
weight
what sir is asking is, what are we looking at? Which are the areas affected in the baby based on history?
Sir, one possibility could be intracranial malformation can present like this.
Congenital malformation.
So what are the problems of the baby currently? Which areas? Means, is there a problem in development?
Yes.
Differential or global?
Global.
Global developmental delay. Are there motor problems?
Yes. In the form of, as described by mother, stiffness of the limbs.
So which means increased tone.
Increased tone.
Okay, so there is a disorder of posture and movement, and there is global developmental delay. What sir is asking is that, are these the problems that you expect in congenital infection?
No, sir.
So therefore that fever or rash, all that is okay. So, and you could have other like congenital malformation or some genetic issues which can lead to these problems. Okay.
Could be a metabolic disorder. Has to manifest sometime.
Yes, possibility is there. Hypoglycemia following the birth that would have unnoticed. I mean, now it would have presented like this, or inborn metabolism can present like this. But it would have been presented much early, inborn error of metabolism like seizures, fall feed, or anything like that, sir.
If
But
hypoglycemia is unnoticed, it's unlikely to present so severely delayed so early in life. He could just go a bit slow and only a mild degree of delay. So that's not right. What about inborn error of metabolism? You will say something?
IEMs can present like this, sir.
IM presents in two ways. One, acute manifestation, and one, chronic manifestation. Acute manifestation is vomiting, irritability, seizure. Okay, that's typical. One is a chronic manifestation. What are chronic manifestations? Storage.
Storage disorders.
Okay, could it be an infantile gauchage? Now we will find on abdominal
examination.
Yeah, so the type of inborn error of metabolism which comes slowly is a storage disorder. Whereas what you are talking about is an acute onset which always comes with seizure, vomiting, refusal of feed, manifests almost like sepsis in an acute situation. So then we'll keep in mind whether this is any form of a subacute or chronic metabolic disorder, which means a storage. What storage will be difficult to guess on examination. So I will ask for a history of abdominal distension. Most of them will have a liver and spleen enlarged, besides many other things. So we'll keep that in mind. We'll also ask the mother whether she has observed the head to be larger than normal or smaller than normal. Oh, that might give us also a clue whether it is a microcephalic or a macrocephalic. Difficult for this mother at 10 months or 8 months to know whether the head is big. Anyway, the head is big of an infant. But you need to kind of ask further on that. Once you have all this, then you should also make a mention about any swallowing difficulties. That means any cranial nerves involvement. Okay. Peripherally, whether everything is moving well, all that. Which means many of these delayed development children may have difficulty in swallowing because in coordination they may have a peripheral neuropathy, so some things may come up in history. So get all these details, we'll get an idea, because this child does not have any clue to why this has happened, right? Yeah.
You'll examine the baby.
So in fact, on examination, we are looking exactly what I said so far. We are looking at the head circumference. We are looking at liver and spleen. We are
Overall
looking at the fundus. Okay. And rest of it is known already. There is a delayed development, there is an increased tone, there could be spasticity, rigidity, dystonia. That won't help us to say where we are. But what will help us is head circumference, fundus, and liver and spleen. Any peripheral signs, whether some reflexes are gone, okay, or just brisk, that is where we'll go by. So again, somebody accept him. Yeah. If nobody comes, he will come running. So you want him only to every time do well so that he passes definitely. Come on. Anybody wants to come? No, then you better come. Come. Yeah, come. Very good. Good. First the inspection.
The child is conscious, not interested in surroundings, not making eye contact. There seems to be the posture, the decubitus is suggestive of an increased tone in the upper limbs. And nutrition wise, the child looks averagely nourished. There are some automatic movements of lips present.
head to toe.
The skull looks slightly smaller for the age of the child. The AF is closed. Only the outer table admits the tip of the finger. Then facies look slightly dysmorphic. There is wrist widening present, no beading of ribs or and,
So when you said there are signs of hypertonia in the upper limb, what did you mean exactly?
child has kept the
Cortical,
limbs flexed and there is the palmar grasp is still present.
Actually,
Is it a decorticate posture? Upper limbs flexed, lower limbs extended.
Spontaneous movements are present.
No, is it you said posture, upper limbs are flexed,
Mm.
lower limbs are extended. Is it decorticate posture? That will tell you where the lesion is.
Yes.
If we were suspecting a decorticate posture, the child should not have spontaneous movements of all the four limbs. Child is conscious.
The child is having a small head. There is no decorticate. The consciousness of the child is a point against the.
And sensorium is when the patient is already unconscious, then for motor evaluation we can see if there is a decorticate or decerebrate rigidity.
So in short, decorticate posture is seen. Decorticate means cortex is cut off. So if cortex is cut off, you can't be awake and open eyes and all that. No, so therefore there's no question of calling it decorticate. Okay. So what I was trying to say is that you look for cortical thumb. So if there is a cortical thumb, then you call it as a sign of pyramidal sign or a spasticity sign in the upper limb. So he doesn't really have a cortical thumb, and he's keeping his hands open as well. Okay. So can you see this? What is this?
Flexing.
Flexion of the
Great.
metatarsal.
So it's almost like a spontaneous plantar without even doing anything is this flexion. So make a mention of all these observations and fine. I think on inspection most of dysmorphic features you added on later. That was something which was also important. Okay.
Hyperpigmented macular hyperpigmented macules over the left lower limb. Could these be counted as any neurokinase marker, or these are just any other findings? Because we've cleaned the place and evaluated on
Again, it depends on size and number. Prepubertal
not
stage.
exactly delineated, but it is quite significant compared to the other limb. And there's been no history of any skin disease also in the past in that region, or any rash, or it's not suggestive of anything like a inflammatory hyperpigmentation. There are quite many.
Personally, I feel they are not discrete macules to be, taken as cafe spots or something. They are very ill-defined. Okay, so that's why you can't call them as those. Okay, go on.
Starting with the CNS examination.
I think first do developmental examination.
First, observing the position of the baby on the bed. Baby is assuming a position of increased tone, characterized by flexion of the upper limbs and most of the time extension of the lower limbs, suggesting increase in the tone of the anti-gravity muscles.
Next.
There is a head lag, complete head lag. When you're pulling the baby to sit, there is a complete head lag, and the contour of the back is rounded.
That's again spasticity. In spasticity, the head and neck is held much before even 2-3 months. And here is the head lag. And you said his tone is
It
increased.
could be the axial and the appendicular difference. That there's axial hypotonia.
Okay, so one explanation you are saying is there could be axial hypotonia, but what does head lag also depend on, or lack of head lag or head control depend on? Does it depend only on tone? So what I am saying is a normal newborn who has normal tone at 3 weeks or 4 weeks, will his head also not lag? So will every normal newborn of 3 weeks be called hypotonic? No. So why is his head lagging?
maturity is of that low level.
So, but what could we give as a reason?
So, no, so that's what. So, head lag is either because of hypotonia. Sir is saying if there is hypertonia, the head may be stiff. So, a child who's developmentally, let's say, age 1 month, but is holding head, you explain that this is not head holding, but this is hypertonia which is doing it, right? So in you to also assess the developmental maturity of the child. So in this case, head lag is not because of hypotonia, it is because his developmental age is less than 3 months. You understood? Go on. So you check pull to sit. What else will you check? Which other positions do you check?
Ventral suspension.
Yeah.
Momentarily lifting the head above the plane of the body. So, which is a
Around 4 months of age.
momentarily lifting the head above the plane of the body. We'll not say exactly that he has achieved some milestones.
So that's corresponding to what age?
2 months
2
of
months.
age.
Yes, around 8 weeks.
So now your initial pull to sit was almost low at birth. And now when you put prone, you said 8 weeks. There is a disparity, right?
Yes.
Yeah. So there you might say there could be axial hypotonia as well. Because this is showing 8 weeks, but that is showing not even 4 weeks. So there must be some other factor, right? In many of these neurological conditions, all kinds of tone exist in the same child.
Yes.
There could be hypertonia, spasticity, rigidity, dystonia, all in one, depending on what are the fibers which are involved. So that's the way you would explain in this.
Now you want to look for any neonatal reflexes.
The glabellar tap, there is persistent eye blinking even after a couple of taps. Ideally, it should have stopped after 3 or 4
Okay.
times.
Look for commoner things, no?
So, Moses, there is extension, but there is no return of flexion.
So what will you say?
Incomplete Morose
Hmm?
reflex. Incomplete Morose responses.
Okay, but is it expected to be there at this age?
6 months will disappear. Around 6 months it will
Yeah, so
disappear.
it has to disappear long back. What is the age of this child?
10 months.
10 months. So even if there is a incomplete morose, it is abnormal. So persistence of morose reflex is abnormal. What else?
Grasp.
Grasp.
He is having it's difficult to evaluate the grasp reflex because there is a grasp reflex is present.
See, no. So see, first you have to decide whether the hand is always fisted already. If the hand is always fisted on already, there is no question of looking for a grasp reflex. Okay? If the hand is open, then you look whether the grasp reflex is persistent. Okay?
In the intermittent. He keeps doing this all the time, and very occasionally he releases a. Do we still do it?
So this is not always fisted. You see now he is keeping it open. So when he is keeping it open, that time you check and you see whether he is grasping your finger.
TNR.
Asymmetric tonic neck reflex, you want to try? How does one look for that?
And first, do you need to try? Does it come after moros have disappeared? Or it comes before moros disappear? If it comes after moros have disappeared, then there is no reason to even do it. So when does
when ATNR disappears, that time the rotatory movements will come. That means before disappearance of moros, the ATNR has to appear.
You are saying ATNR disappear. What is the significance of ATNR?
It means rollover. If
Correct.
that disappears,
So
then
it is only when asymmetric tonic neck reflex will disappear that the
Then
baby
only
can
baby
roll
can
over.
roll over.
Correct?
Yes.
So that is about disappearance. Sir is asking about appearance.
5 months, approximately 5 months.
5 months baby rolls over, no? So 5 months is the age for disappearing. But appearance, first moros disappears by 2 months and then the ATNR will come. Correct? So means again these are telling you how developmentally delayed this baby is. So if you have a asymmetric moros, you had your judgment of between neonatal 0 to 4 weeks or about 8 weeks. So this baby is, everything is pointing to less than 8 weeks. Okay. Okay. What else do you had examined earlier? So any other findings that?
The baby was conscious. Cranial nerve examination. The baby.
What about vision? You think baby can't see?
So he intermittently follows light. While holding a torch and moving it from one end to the other, intermittently he follows the light and loses interest in that and starts looking. Again he starts following the light. And there's pupillary reflex bilateral normal and corneal and conjunctival reflex normal. He doesn't turn towards the direction of sound. Their extraocular movements are present in all the directions.
But can he hear?
Sir, I just wanted to ask this query. Like we made a loud noise behind the baby. So there was flickering of the eyelids at the loud noise, but he did not turn towards the direction of sound. So can we quantify this response as a response to sound, or do we always have to look for a turning to the direction of sound?
Answer her question. Anybody?
Because considering the tone of the child and the movements he is able to do, can we quantify the response that he is able to respond to?
Come on, quick. So does the baby have to turn to sound for you to be sure that this baby can hear? Is the question. Please take the mic. Please take the mic.
Was there any visible change in behavior or facial expression in the form of alertness or
There was flickering
type of startle or
eyelids, like
something
a startle. Every time there was a...
that may correspond?
Perfect. So whether baby can hear or not is decided by a change in behavior with a loud sound. Turning to the sound is localization of the sound, which will come in a normal baby at 3 to 4 months of age. So if this baby is below that, this baby can't localize sound, but doesn't mean cannot hear. So if there's a change in behavior, then the baby can hear, which a 1-month-old baby will do. So 1-month baby will either cry if quiet or quieten if crying with a sound, which means it can hear the sound. Okay.
The other cranial nerves which could be assessed were the gag reflex was present. And
What was the head circumference?
head circumference is 36.5 centimeters, which is below the
Normal?
-3 standard deviation for the age.
How do you say that?
Sir, the baby is currently 10 months old at birth.
The birth circumference, right? You don't know the head circumference at birth. How are you so sure that this is normal? That is very important part of my final diagnosis. So convince me.
Tell us the other parameters: growth, height and weight.
The head circumference is 36.5 centimeter, the chest circumference is 43 centimeter, the weight is 6.5 kg and the length is 65.5 centimeter. The MUAC is 13 centimeter.
Length is?
And 66.5.
66.5. Okay. So answer sir's question that when you don't know the head circumference at birth, how do you decide in a given child whether this head is small for this child or big for this child or normal?
Correlation with the length of the...
Very good. So do the correlation with the length. You said 66. So what is the formula?
Oh.
Anybody? Half length. Please take the mic, whoever is speaking. Take the mic.
Length divided by 2 plus 9 plus or minus 2. In this case 66 divided by 2 33 plus 9 42. So 42 44 you can expect. So it
So
is
42 plus or minus 2.5. So that's say 39.5 to 44.5. So for 39.5 minimum, this baby is 36.5. So what does that tell you? Definite microcephaly. Now what is the interpretation one step further of this microcephaly? You have to tell me what did you infer from this microcephaly, which is 36.5 in this baby? More than primary, I want to know when did it start?
Symmetrical or asymmetrical? For that again ponderal index has to be.
No. वो सब में नहीं. अभी tell me when this small head started. So means can you guess logically
before, I mean it is intrauterine insult rather than postnatal or postnatal, sir.
Okay. So it is prenatal.
Prenatal.
Okay. How do you say that?
size of the head during the delivery.
Is what?
Like if a prenatal the child the head will be like small and it will not grow.
No, agreed. So even somebody who had issues at perinatal period, that head will also not grow, no? So the point is that this head is so severely small in spite of no issue at the perinatal period. So that is your strong point in favor that this was always small even prenatally. Okay? So that makes it what we were talking on history, that this is a prenatal cause of developmental delay and disorder of posture and movement. What we were talking on history, we were saying now that there is no natal. So this is prenatal because the head is so small. Okay. Okay. What else? Any other?
Motor system. There was increased tone in the upper limbs and the lower limbs, and there was more tone in the lower limbs while compared to the upper limbs.
Hepatosplenomegaly?
Sir, the liver is just palpable.
Okay.
The spleen is not palpable.
So, what is the root? Yeah.
When we are eliciting reflexes in a hypertonic child, so I'm attempting to flex his knee. Can you watch me up? Attempting to flex his knee, but then because of the tone, he automatically does this. So in such a case, how do we still go ahead with eliciting? But again, when I'm trying to do, I do this and he does this. I mean, I try to flex it and he does this before even I strike it with a hammer. So in the exam, how do we handle with such a situation when we are given a...
So what is that known as when he goes into a stiffness as soon as you touch him?
Clonus can go like that.
Dystonia, no? So when you touch him, he goes stiff. That means he is dystonic. So you tell the examiner that he is so dystonic that I can't take the reflexes, because for taking a reflex, what is a reflex? It is a stretch reflex. So stretch reflex means you have to stretch the non-contracted muscle, then that muscle contracts. That's your reflex. If the muscle is already in contraction, how will you take the reflex?
So
Right?
in such a case, ideally to.
So what's your final diagnosis?
10-month-old male infant with no perinatal significant perinatal history, with global developmental delay, partially immunized, with microcephaly, with no feeding issues.
So you will say,
Diplegic cerebral palsy.
you said
To rule out
that
a
there was
structural.
consanguinity, distant consanguinity, and you will say that severe microcephaly in the absence of any significant perinatal history, suggesting a prenatal cause for the microcephaly, suggesting a genetic issue, or then you debate. What about metabolic? So sir already discussed on history. Congenital infection, do you think is still possible?
Less likely on examination. No.
Correct. So on examination, nothing to suggest congenital infection. So either a structural malformation or any other genetic prenatal cause. Okay.
Actually, when you talk about the prenatal condition, you have only three: congenital infection, chromosomal disorders, or a congenital malformation. Well, you may add on to say maternal drugs, alcohol withdrawal. All those are not really common features, and this is not the way it progresses. So antenatal causes three. Postnatal, perinatal causes hypoxic ischemic, hypoglycemic, bilirubinemic. Okay. So it's simple. Three antenatal causes, three perinatal causes. Postnatal events obviously known, like a meningitis, etc. So you would debate between three antenatal causes here and say congenital malformation or a chromosomal disorder. Chromosomal disorder may not be just trisomy or anything, many deletion syndromes, etc., which we won't know. And I think that would be the way to go by.
How will you investigate this child?
Firstly, the child presented to us with convulsion. So to work up for the same complete blood count, to look for the total count, electrolytes, blood gas, ionized calcium levels, blood sugar at the time of presentation, and
Did you think that convulsion was, would you like to categorize that convulsion? Do you think it was acute symptomatic, remote symptomatic, or idiopathic?
it was at the end of our examination could be remote symptomatic due to the.
Why did it take so many months to seizure? Damage is severe, came so early, but the seizure came pretty late.
Again, it explains the difference between seizure and convulsions. You would have had epileptic foci inside the brain. The threshold of a foci is not that much to manifest as a convulsion. Now the threshold must have reached to convulse, or there is a history of fever. That could be the triggering factor to increase the.
But the history of fever was prior to the.
So you're
onset.
brilliant.
So at the
What he's trying to say is that there is a period of epileptogenesis. Okay. It takes time to develop. And what he says that thing was developing but not manifesting. And that's why he talked about convulsion, seizure, etc. Yes. So not every time you will have a seizure as the first manifestation. But when the seizure is the first manifestation, it's an acute metabolic disorder. Otherwise the seizure comes any time later, could have come even in 2 years, 3 years, 4 years, depending on how long it takes. So it's called as a period of epileptogenesis. It takes time to develop. That's why he would have. Point is, would you have done an EEG? before he convulsed.
Before. Yes.
Yes, sir.
And what would you have done if that EEG was abnormal?
It would have assessed the, prognosis, or I would have predicted, should I start with smaller dose of
So that EEG will not help you take decisions about whether to put the child on anticonvulsant therapy or no. Nor can it predict whether he will get a seizure at 10 months or at 10 years. It will not predict all of that. Okay. So therefore, to that extent, that EEG is not helpful at all.
Yeah, but all your investigations were for metabolic conditions.
No.
So therefore, acute symptomatic seizure, not for
So
this
what are the
situation.
features which will tell you that this is an acute symptomatic seizure? Or not even acute symptom, inacute symptomatic metabolic. What is the hallmark of a metabolic seizure?
Are you getting what he is
Yes.
saying? Yeah. Anybody? She is not alone in the line of fire. Come on.
So what do you see in a child who comes to you with hypocalcemic seizures?
You've seen a hypocalcemic
Yes,
seizure?
sir. What is the story
So
like?
what is striking in that? Which is different from a meningitis child who's having a seizure?
The child was very much all right prior to the onset.
Very
Okay,
good. So
and-
what is
And
suppose he has multiple seizures.
and during crying, it is the child is more likely to throw convulsion because
Okay, and how is his behavior between two episodes of seizure?
Absolutely normal.
Absolutely normal.
normal.
So that gives you a clue that this is a metabolic issue. Yeah, there is no encephalopathy.
okay? Okay. Will you do a imaging in this child?
Definitely.
Why? Why
So-
definitely? We always said no. CP, it is of no use. How does it help to plan treatment? This, that.
Why
And all-
waste resources?
Again, to explain the prognosis and
What prognosis? How will the CT help you to decide prognosis? This is a 10-month-old child whose developmental age is around 1 to 2 months. So your DQ is about 15%, which is like profound. What more now? You just follow up. No, what CT will tell you about prognosis?
attempt to rule out any structural malformations, which
So
could be the
suppose there is a structural malformation. So what?
again it depends on the type of malformation. To prevent further pregnancy means second offspring, like cerebellar encephalomalacia or that type of conditions can present in second pregnancy. To prevent that, we have to give a folate, folic acid supplement. So to prevent further child getting affected from the same
Very
disease.
good. So how would you have said the same thing, that in any child with suspected CP and MR, if there is a normal birth history, it is a sure shot indication for imaging. If there is consanguinity, it is a sure shot indication for imaging. So these two things are operable.
And if the head circumference is now just
is
completing the list.
So I'm coming to others. In this child, head circumference is small, but if you have a CP with a normal head circumference, it is a indication for imaging. If you have a CP which is familial, so more than one child in the family looking like CP, it is an indication for imaging. Okay. So normal birth history, normal head circumference, consanguinity, familial looking CP, these are signs for indications for imaging.
Now they said distantly consanguineous. Is that significant? What is distantly consanguineous? You said that in your story.
Yeah.
What does that mean? I think all humans are distantly consanguineous.
If there was something like a 5th degree consanguineous marriage, he would probably have fit into that. So I
Yeah,
would
so
not
then
know
it's
how to-
this consanguinity
Then
doesn't
it's
fit
not-
in.
So we
Yeah.
label such things non-consanguineous.
Yeah. So we'll stop. Thank you. I'm sorry I forgot to introduce her. So she is Dr. Nikhila from Sion who presented this case.
So some announcements before we wind up. The next broadcast will be from Chennai, Kanchi Kamakoti Child's Trust Hospital
on the 13th of January, starting at 2:30 p.m. and Dr. Bala will be conducting that. At the beginning of this broadcast, I told you about our proposed STEER program for postgraduates. For those who are joining in now, I would like to tell you about it again. STEER is a program which stands for Sensitizing to Think, Enabling Excellence and Rationality. It is a program which has been started by Dr. Amdekar, and this time the focus of the STEER program is the postgraduate, and this will be held on the 20th of March. Now the purpose of informing you about this is that it will be held at Sion Hospital in Mumbai, but we are planning to webcast it. And so we would like you to mark that date in your calendar and tell your friends and colleagues about it so that you can take the benefit of Sir's teaching even from where you are. Thank you so much for joining us today. See you next week.
Wait a minute, I don't want anybody to leave the hall. Oh, हो गया, बंद हो गया webcast.